us. But I would like us, in the interest of time and to respect everyone who's taken the time to join us on this call, to get started. So my name is Tian Johnson. Thank you everyone for joining the webinar. I'll take this opportunity to just share with you a bit about who is behind these webinars and what we aim to achieve today. The webinars, colleagues, are hosted by the Vaccine Advocacy Resource Group, which is a global group of advocates that work to ensure that vaccine research is accountable and community owned. The Vaccine Advocacy Resource Group is 100% funded by advocates themselves. It's also brought to you by the African Alliance, which receives support from the SAMRC and the Department of Science and Innovation, and they support our work to ensure that COVID-19 research is accountable and community owned. We also bring you these webinars in partnership with APHA and the Community Constituency COVID-19 Front. So thank you to all of the partners for making this work possible. Today we're joined by Professor Glenda Gray. We've all seen her quite illustrious biography, and that has been shared in the invitation. So Glenda, welcome. The structure of this call, colleagues, is that all lines will be muted for the entire duration of the call. You may feel free to put in your questions, your comments into the chat box. The structure is that the questions that have been submitted in advance will be prioritized to be addressed during this call, and then we will go into the chat box. Any questions that we do not get to during the duration of this call, we will get to in writing in a post-call report that will be circulated a week after this call. So without further delay, we're going to ask Glenda, welcome. Thank you for making the time to be with us. So Glenda, share with us, if you may, an overview of the MRC and its mandate and some high or low lights of the work that has been undertaken by the MRC since the advent of COVID. The landscape is clearly evolving rapidly and has not been free of controversy and an abundance of mixed messaging around transmission, risk prevention, mortality, and in recent weeks, certainly alcohol and children, all of which you and a team of several dozen leading scientists advise the government on. If we can cover that in the next 20 minutes, and I'll let you know when you have 2 minutes left, and then we can get on to the Q&A. So I will proceed to unmute you, and over to you, Glenda.
Thanks. It's hard to have you controlling whether I can speak or not, having you mute me. Can you hear me now, Tian? Are you able to hear me? Can you hear me? Is everybody able to hear me? Cool, you can hear me. Okay, that's great. Good evening, colleagues and comrades and scientists and advocates. I'm from the MRC, so I'll just give you a bit of a background. I'm a doctor trained as a pediatrician who worked at the perinatal HIV research unit and established it to look at interventions to prevent mother-to-child transmission. And after that, became involved in HIV vaccines and led the first South African developed clinical development of an HIV vaccine. Later on, in around 2014, I went to the MRC and became the president of the MRC. And since then, are focused both on HIV vaccine research as well as leading the research and development of the MRC. So the Medical Research Council's mission and vision is to fund and conduct research that changes the lives of South Africans. And we orientate our funding to the 10 most common causes of mortality and morbidity in the country. And so we look at the first 10 because of our, because we have resource constraints, we focus on the top 10 and we fund everything from basic science through to clinical development, through to public health research, surveillance, as well as social science and behavioral research. And so we have a whole program of research that focuses on trying to find interventions to impact on the lives of South Africans. So fast forward to March, when we started to realize that COVID-19 was going to also affect South Africa. So we had been watching this epidemic from late December, early January, when we started to get reports that there was this cluster of pneumonias of unknown etiology that were causing increased mortality in China. And then in early January, we started to hear more about this disease. We started to hear about the devastation in Wuhan, and we also started to see the emergence of this epidemic in cluster outbreaks in the US and in Europe. And then pretty soon, within a couple of weeks, the WHO announced that this was a pandemic, and soon thereafter, on the 27th of March, the country went into a lockdown. And the aim of the lockdown was to try and curtail community transmission of COVID-19 and to prevent any more international transmission of the epidemic of the virus, and that is the reason why the borders were closed down and inter-provincial travel was curtailed. There are two aims of doing a lockdown, and one of the first aims is to get the hospitals and the medical health system ready for the medical parts of the epidemic when the surge comes. And the second part of the lockdown was to try and curb community transmission. And you curb community transmission in a couple of ways. One, you implement non-pharmaceutical interventions, and at the same time you scale up community-based testing, contact tracing, and quarantine and isolation. And we started the country started the scale up of testing around the Easter weekend. However, because of the lockdown and the international and global shortages of kits and tests, there was a lag in the scale up of testing. And so South Africa was always underpenetrated when it comes to testing, and which led to an inability to actively trace and contact people. On about the 5th of March, when it became apparent that South Africa was going to also be impacted by the epidemic, the DG of the Department of Science and Innovation phoned me and said, Glenda, what is going to be our scientific strategy for COVID? And I was in Durban at that time, and I was on my way back to Cape Town. So during the flight from Durban to Cape Town, I put together a draft research strategy for further input. So at that stage, we knew that there was a global shortage of tests, and so one of the research strategies we put together was mechanisms to try and fund local production and local manufacturing of PCR kits. So that was the first thing, increase the amount of testing we could do. The second thing was about surveillance. So we didn't know what COVID-19 was going to do in South Africa. There had been reports that from China that the men were more affected than women, that the older you were, the more likely you were to have more morbidity and mortality, and that the age was really impacted on outcomes as well as comorbidities like hypertension and diabetes. And we also had two different epidemics in South Africa as well. We also had an epidemic of HIV and TB. So we didn't know at that stage what our natural history would be in South Africa, and whether we would have a different outcome as compared to the rest of the world. By that stage, we were hearing reports about the epidemic being out of control in places like Spain and Italy and France. And so we rapidly funded surveillance in South Africa. So we funded NICD to do surveillance on HIV and TB and SARS-CoV-2. We also funded Shibri Mahdi to do surveillance at Baragwanath Hospital and other hospitals in the country to look at pregnancy, children, and medical admissions to see whether we could understand what was happening at a public health hospital. We were also concerned about the lack of treatment interventions at that stage, and we and we put together programs to look at clinical trials, and with that we invested in the crown coronation prophylaxis study for healthcare workers, as well as the solidarity trial with WHO. And in addition to that, we also funded various other clinical trials in South Africa. We were looking at various interventions, various antiviral interventions, and other interventions that look promising. We had a long discussion about the ability of South Africa to respond to vaccine development, and we put together a team to look at what we could do. And we looked at vaccine design, and also following up people who were COVID positive, following them up long term to look at their convalescent sera to see whether we could use that. Start to develop convalescent sera, see if we could use that as a way of treating people either who had COVID-19 or who were exposed, as well as looking at identifying what kind of strains of COVID-19 we had in South Africa, as well as the development of neutralizing antibodies, and trying to understand a little bit of the immunology. And so we funded Penny Moore and Lynn Morris at the NICD to try and understand some of the immunology and some of the molecular biology of COVID-19. We also worked with Rachel at the CSIR to start looking at monoclonal antibodies. She was collaborating with people in the Netherlands, and we looked to see whether we still are evaluating whether we could use some of these monoclonal antibodies in prophylaxis and treatment. So that's an ongoing study as well. We put together a consortium to try and develop other rapid diagnostics, and so at that stage we thought we could also not only look at the RT-PCR capability of South Africa, but also to develop some capability in developing antibodies, serology, to diagnose, to do seroprevalence studies, as well as and trying to find cheap antibodies for surveillance and for trying to understand the immunity of COVID-19 in South Africa. At the same time, we also got involved in a whole lot of other strategies to co-fund the first COVID vaccine trial in South Africa, and this is the Oxford study. So the MRC is a significant funder of the study, and we're funding particularly the study that looks at the chimp-ad COVID vaccine in HIV-infected individuals. So we will be funding that study completely, because we are very interested to know that it can be, that what the immune responses are of people who are HIV-infected on treatment, and whether this vaccine is as immunogenic in HIV-infected people as non-infected people. So we're very committed to making sure that we understand our burden of disease, and that we evaluate the vaccines in the communities that are where it's appropriate, and also where we can find information. We don't want to have a COVID vaccine that is registered in this country and we don't know what it does and how immunogenic it is in HIV-infected people. So it's very important for us to make sure that in every trial we do, HIV-infected people are represented. We also are working with HSRC, because not only is COVID-19 a biological or infectious disease, it has tremendous social impacts. So suddenly we're in a situation where when our sick go to hospital, we're not allowed to go with them. And so this is highly unusual in South Africa. We drop our sick relatives off at a hospital. They go in with their cell phones, and we try and we see relatives having to try and navigate the care of their loved ones through cell phone and other mechanisms. So it's very unusual in the situation where you're not in touch with the people that are sick, that are your family, and your family move on in hospital. They go on oxygen, they get ventilated, and you don't know what's going on. So that's very traumatic for families. It's very traumatic for for everybody, for the person in the hospital, as well as the person, as well as their relatives. And so try to understand a little bit about that. We know that it's also incredibly hard because when people die of COVID-19, the whole way we mourn has changed, and a lot of our cultures have certain ways of mourning, and this has taken away the way we greet people, the way we hug people has been removed as we have to handle this epidemic. And so we've also tried to work with the HSRC to try and understand some of the psychosocial impacts of COVID-19 on families, as well as on healthcare workers who are tremendously affected by working with patients that are getting sick, and where there's very little that you can do, particularly when they start to get very ill. And so it has a tremendous burden on nurses and doctors and allied healthcare workers who are navigating in the coalface trying to manage this disease. So it's a very traumatic experience for a lot of healthcare workers, and will cause a lot of trauma, particularly when you can't give them the best standard of care that you want. So that's another aspect that we have to look at and not ignore in our research as we try and find solutions for COVID-19. As well, so there's a lot of reorientation. So we managed to look at our budget and move all kinds of resources, all kinds of money to try and make money available. And we were able to find about 100 million Rand to fund all this research in South Africa, as well as getting money from the Department of Science and Innovation, who've given us between 30 and 50 million. Because we were running out of testing capability, the MRC and the NHLS collaborated together to create an academic surge program, and we got money from the Solidarity Fund to fund academic centers in all parts of South Africa, including historically disadvantaged institutions, to scale up testing for COVID-19. So that's part of the work that we've done. At the same time, I guess in the work at the MRC, one of the things that we have been as one of our objectives in the MRC has been to not only fund science that's going to change people's lives, but also to build capacity and address transformation issues in South Africa, as well as knowledge translation. And that's why we're having one of these. That's why we're having these webinars. So we've added a fifth strategic objective to the MRC, and that is knowledge translation, and to take knowledge out of the Lancet and the NEJM and high impact journals, and to make information and make science accessible and available to everyone in South Africa. We've become an open science council. So we were we are the first institution in South Africa that has aligned itself to open science, which means that all science that we fund and all journal articles that are published that have been funded by the MRC have to be freely available online. So if you go into the Lancet, if you go into NEJM and there's something that we funded, you'll be able to click on that article and you will be able to access it. And so we insist on that. There's one of the other things is to try and make science more accessible. In terms of capacity development and transformation, when I came to the MRC in 2014, I did an analysis of who we funded, where we funded, and how we funded. And based on that, I found that we funded a lot of the Ivy League universities, Wits, Stellenbosch, and UCT, and we funded a lot of white men. And so over the years, we've changed that. I've created two streams of research, one for research funding, one for early stage investigators. And so what was happening was that the early stage investigators in our country weren't getting chances because they had to compete with people that had a lot of, who knew how to write grants and who had a lot of practice. And so these poor people weren't getting in on the door. So we split our funding streams to have an early stage investigator funding stream and a mid-career to late-stage funding stream. We also realigned our peer review to take into account being women, being from a historically disadvantaged institution, and also we looked into issues of race, and all our research is internationally peer reviewed. And over the last 5 years, we've managed to increase the amount. So half our funding goes to women, first of all, so that's a good thing. And we managed to increase significantly the amount of funding that goes to Black scientists, and that's all available. So that's in our annual review. You can see year on year how we've improved. So this is an indicator. So we track our progress. So that we report our progress on our annual performance plan, and we report our progress every quarter. The movement we made. So another thing that I've done is I'm concerned about the lack of. Okay, I'm concerned about the lack of women and Black scientists in mid-career to senior science positions. So I created a program where we award mid-career scientists research money to basically catapult them into scientists that will become leaders. And this has worked because most of the people that we funded in that area have become SARCI chairs, have developed extramural units, and have gone on to the next stage of science. I also did I've also made sure that where there's a deficit in sex parity, I've stopped men applying. I've only made the grants available for women. And so we had a situation where we have extramural units, and I was concerned that not enough women were applying to be extramural units. So we have calls until we have parity. We will only allow women to apply for those extramural units. And once we have parity, then we'll open up the competition again to men. So I am committed to making sure that women scientists advance, and I'm also committed. I have a track record, as is evidenced by our review, that we've made significant progress in terms of transformation since the time I've been the president of the MRC. So I think I'll stop there. So I've kind of like given you an array of the stuff we've done generally around COVID, and also our commitment to research translation and capacity development.
Great, thanks so much, Glenda. So Glenda, we've had some questions that have been sent in advance, some of which you've addressed. The one was specifically around, under your leadership, what has the MRC done to specifically advance and support Black women scientists and the broader transformation agenda, and you've covered that. We'll also reach out to you after this call to flesh out some of that detail in the report that we share after the call. So thank you for that. The other question we have is, what is the MRC doing to ensure that the COVID-19 response does not take over general health services for communities?
Okay, that's a very good question, and something that has concerned us. I'm sure that you know that we do this for 30 years. Every year, every week, religiously, MRC puts on its website the mortality rate of the previous weeks. And so this report has been critical because it's tracked certain important periods in our time. So there was a time in South Africa where people did not believe that HIV caused AIDS. And if it wasn't for these people every week putting out the death reports, we would not have been able to prove that HIV caused AIDS. So these people who put out these death reports showed that there was an increase in mortality happening in people that never happened before, in women, young men and women who were in their 20s and their 30s. And this was the evidence that led to us being able to show that HIV caused AIDS. And it also led to the evidence to show how ARVs worked in our country. So by charting these death rates over time, we were able to see with the advent of ARV rollout how we increased life expectancy and how the dynamics of death change in our country. These reports have also shown us how infant mortality rate changes, and we also were able to alert the government that neonatal mortality rates hadn't changed and that maternal mortality was similar. So these reports are like what we call the canary in the coal mine, and they help us alert the government and the health system about what's not working. And so the kind of intervention we did about 2 years ago, when we showed the government that neonatal mortality wasn't changing, and it wasn't changing because children were dying because of poor obstetrical care and because of poor care in the first 28 days of life. And this was an important highlight. We've also been tracking, because of COVID, we've been tracking TB and HIV diagnosis and CD4 counts and viral load, and also immunization rates, to alert the government that we're not diagnosing enough TB at this moment in time, and that we've decreased the amount of viral loads and CD4 counts, which means that people aren't accessing care, and so that's an important indicator. We also are concerned about immunization rates, and we have seen a decline in immunizations in this period of time. And so what we have to do is we have to alert people to say, this is what's happening. People may be too scared to come to the clinics, and that's why they're keeping away. And we have to try and change the narrative that people who have chronic diseases, children who need to be immunized, are getting to the clinics. And by having data, data is very powerful. Data is the biggest advocate. When you have data, you can have the evidence to show anybody what is changing and what is right and what is wrong with the health system.
Thanks, Glenda. So I think, everyone on the call is quite clear that we'd be doing an injustice if we don't ask this question. So Glenda, you, as have other members of the Ministerial Advisory Committee, have been in the news constantly. And it's clear that you, like the rest of us, are navigating a new and rapidly evolving situation. Could you share some of your reflections on how the scientific, data-based, evidence-based messaging that has come forward, and how it's been reported on and shared, and how it has landed? Reflections from you on that.
I can say I don't think I've ever learned so much so quickly in all my life, and I don't think I've ever known that what I thought I knew last week was wrong, and what I know this week is new. And so I think as scientists, we have to realize is that this is a rapidly evolving epidemic, and the things that we held true yesterday or last week may no longer be true, and we need to adapt or die. And so I think that's an important thing. I think with COVID, there has been an obsession with the news, and the news has I felt that obviously there's always people always want to sell their newspapers, and they always want to get the most hits, and so obviously there's going to be people who wanting to distort for coverage, or want to make controversies or be provocative, and so that's always going to happen. This epidemic is nothing like this has happened since the Spanish flu, and this is different to HIV in that this is rapid. HIV took years to unfold. We had months to years to manage people who were HIV infected, and with COVID-19 it's an incredibly contagious virus. Transmission is rapid, even though people are asymptomatic mostly. There are people who are older and have comorbidities that will get sick, and these deaths are unexpected, and so there's a lot of interest. We've never had to wear masks in our country. We've never ever had to be isolated. We've never had to have social distancing. We've never had to practice NPI. So this is a surreal world that we're living in. Our life has never, since January, our life has changed completely. And so obviously there's going to be interest in this, and obviously scientists are not only in South Africa, but globally, scientists are being called on to help pave the way. And we've seen, scientists all over the world being called in. We see Tony Fauci, we see Debbie Birx and her scarves, and we see the stories of the UK scientists, and we see stories of the scientists in China, the ophthalmologist that alerted the government who died. He was detained when he first called out that there was this unknown pneumonia that was going on. So there's always going to be an interplay between science and politics, and science and the media. In an epidemic like this, unfortunately, scientists are the go-to people. They're the people that are trying to decipher the information and are trying to give the best advice. And remember, the advice can change all the time, because what we thought we knew, we don't know anymore. There was a time when Tony Fauci never wore a mask, and now he wears a mask. There was a time we never wear masks. We were one of the first countries to start wearing masks in public, and this was in early May. I'd have to check the date. It wasn't May. I think it was even earlier than that. So we were one of the first countries outside Asia to adapt to public wearing of masks. And so things do change all the time.
Do you feel that you and the MRC have the political support you need to execute your mandate?
Well, I think that the MRC is a wonderful resource to the government, and we are data driven, and we show evidence, and sometimes the evidence it can be is scary. For instance, I'm sure you've heard on the radio and on the news that we've obviously been tracking death, and since the beginning of the epidemic we found excess deaths in comparison to what the government is reporting. And that's understandable, because people in the beginning, doctors weren't diagnosing COVID on the death certificates. People are dying before they get to the hospital, and people who and you may not be sure that someone has got COVID. So obviously at a global level and in local level, you're going to underreport COVID. And so there's going to be a catch up. You also could over-report COVID, particularly when there's infectious diseases. And so, so basically the MRC is counting mortality. And when the mortality doesn't match with what the Department of Health have got from COVID being a notifiable disease, there's going to be discrepancy. And so you're going to have to explain the discrepancy. And you have to, you have a public obligation to show it, because the research we do is taxpayers, paid by taxpayers, and plus we are open science. We subscribe to open science, and so we can't hide our data. And we have an obligation to show the data that we collect and try and explain it as best we can. And so we do. I've been talking. So sometimes I talk 5 times with the minister. This morning I've spoken to him twice. I helped. So I also had to help with the information for his speech, his budget speech today. And so checking data. So I was in contact, making sure that we had the right numbers for the case fatality rate. Giving him information about what's going on in Russia, the UK, issues around mortality in the ICU, and so on many occasions, sometimes between working with the minister and with his DG, sometimes up to 3 or 4 times a day, we are in contact. We also work very closely with the Parliament. So the Parliament has we report. The MRC reports to Parliament, and so we spent a lot of time with Parliament working on the alcohol issues around alcohol and the curfew, and bringing evidence. We brought the evidence to Parliament about the decline in unnatural deaths with alcohol prohibition and curfew, and so we provided the evidence that led to. I don't want to say we said we didn't say, we said that we recommended the curfew because of the mortality that was happening at night and on the weekends, and we recommended alcohol control, and which is different to alcohol banning, but we did recommend trying to manage alcohol use in the country. In addition to that, we also gave information on the demographics of COVID infection and the various age ranges and the mortality associated with COVID at different age ranges, and helped inform the government on certain recommendations and support around issues like school, and give advice about, based on what we see in South Africa and abroad, various strategies. So I think that the MRC has an amazing amount of resources and evidence that the government uses all the time. And Nkosazana Dlamini Zuma phones Charles Perry all the time to get advice about tobacco and alcohol. And I work with the DG and the Minister on issues around death and mortality, and as does Debbie Bradshaw. And yeah, so I think that we are a resource. We receive public money to do research to help the country, and that's our mandate.
Great, thank you for that. So one of the last pre-submitted questions before we get into the chat box, colleagues, a reminder, feel free to put your questions and comments into the chat box, and we'll get to them as soon as we've heard from Glenda on this question. So Glenda, if money wasn't an issue, what critical work would you fund right now to give us the greatest return on investment to make an impact on COVID-19?
Sure. Okay, that's if money was no object, I would do.
Yeah.
If money was no object, I'd do lots of things. Okay, so first of all, if money was no object, you want to better articulate the natural history of COVID-19 in South Africa and really understand the transmission and what are the factors that make people more or less contagious, so you can give good public health advice. Two, you'd want to make sure that we could have a rapid diagnosis at point of care. So when you arrive at the hospital and you don't know whether you are COVID positive or not, someone can just prick your finger or put a swab up your nose, and in 20 minutes you have a result. That is, to help the doctors, and then to also invest in treatment, so the people that get to hospital, that they don't die, and then to look at, and therapeutics, to invest in therapeutics and treatment antivirals, and then to really invest in vaccine development, so that we can be part of the global endeavor. So we are putting money in, but when you look at the amount of money the NIH puts in, we just it's like it's minuscule in comparison then to that. And then also the issues, the psychosocial, the cultural changes, the depression, so gender-based violence, we see gender-based violence, we've seen depression amongst children, we've seen cognitive issues, we're seeing hunger, and we're seeing malnutrition. And so to address some of those issues, some of the structural and issues, but also some of the things that we took for granted in our country, and we're now isolated. Families are isolated, communities are isolated. We can't mourn like we used to mourn. We can't greet like we used to greet, and we can't go to do our religion like we used to do in the past. And so those all have huge effects on the psyche of a country. And so the huge mental health issues that are associated with this, as well as psychosocial issues, as well as the medical issues. And so we can't just see COVID-19 as a virus that's contagious. This virus has changed everything we do, and all of that has consequences.
Thanks, Glenda. A quick one, I'll take liberties as the host. What Is there a trial, and we asked Shabir a similar question, so it'll be interesting to see what you say. What in your mind presents the most promise or gives you the most hope for a potential solution to COVID in terms of the current research happening? What stands out to you? What do you have your eye on particularly in the sea of research that is happening?
So I want two things. I want an antiviral. So an antiviral where you could take, so if you got COVID-19, you could take this antiviral and it would stop you from shedding, and you would get well and you wouldn't have to go to hospital. So I would want an antiviral. And I'd also want a prevention strategy. So I would want something that that stopped the onward propagation of the virus, so that we could end the epidemic. And so we need treatment. So maybe just much like HIV, we need treatment and we need prevention. And the condom, which is the NPI. So the NPI is very hard. NPI is non-pharmaceutical interventions. It's the mask, it's the social physical distancing, and it's the hand hygiene. And so that's entry level, and it's our condoms, it's our abstinence, it's ABC, and ABC is just very hard to keep up. And so we need to replace NPI and ABC with treatment and prevention.
So a question, thank you for that. A question going now into the chat. Do you think SA locked down too quickly? Did we go into lockdown too quickly?
It's so hard to say. So in the beginning, so you look at places like Sweden, and in the beginning of the epidemic, everyone was saying, wow, like look how well they're doing. But then you look at they have one of the highest death rates in Europe. And they had a different strategy. They believed in herd immunity and going out, and so part of the epidemic maybe they got right, and part of the epidemic they got wrong. And so they believed it was important to get as many people exposed, and but the collateral damage was that there was high mortality in older people. Then you had Germany, that were very good. And immediately they banned any gathering over 2 people. They implemented immediately, maybe that's the Germans, a 6 feet rule. So everybody had to be 6 feet away from everybody else. And but then they also had very high ratio of beds, ICU beds and hospital beds. So they had one of the lowest death rates in Germany, in Europe. And then you had Britain, that has, even though they have very good healthcare, they have one of the highest death rates in the world, 14%, as compared to say 3.8% that you see in the United States. So if you look around, maybe the only people that have done a good job are people in South Korea and Singapore and Vietnam, but even they have struggled. And the only thing that really works is to be able to track and trace and keep your community transmission at low rates. And that means you have to have an infrastructure that can find every person in your country and track contacts and put you into isolation and quarantine. And that's impossible everywhere besides a very few amount of countries in the world. And so if you look at the United States, that's a devastating epidemic. It's just getting worse and worse. And it's getting worse and worse because there's been resistance to wearing masks and social distancing, and there's been confusion about NPI and opening up. And then you look at countries like South Africa, we mimic, if you look at Colombia, Peru, Brazil, to some extent India, we follow the low middle income country trajectory, where we can't contain our community transmission, and we can't contain our community transmission because we don't have enough testing. So we're underpenetrated with testing. We don't have enough testing, then you have 10 days turnaround time. It becomes very hard to control your epidemic. And so I don't know if there's any single one country that I could you know, but besides, if you live in South Korea or Singapore, if there's any single country that we could emulate, given our doctor to nurse ratio, given our fragile health system, and given our testing paucity. So it's very hard. And then you look at the issues around the economy, and you see that every economy has stuttered because of COVID. And so I think what you have to do, each country has to look at itself and, you know, close off its mind. Don't listen to, you know, WHO gives advice and it's kind of generic advice, and maybe that advice doesn't fit for you. And so countries need to look within and find strategies that that work for their country, and not always look at emulating the first world or things like that. And so we don't know whether we when you look back, if you look at our epidemic now and you look back and think, okay, well, maybe it could have been different. You know, some people do say we should have closed down later. We should have closed down when our testing system was up and running, and you know, and maybe the whole closing down didn't take into account the fact that we couldn't get food to people, and we couldn't get you know, we couldn't make people poverty secure, and that also affects your outcome. You know, if we were able to get food to people and make people more financially and resilient and food resilient, then maybe our outcome could be different. And so it's kind of like, you know, the grass is always greener on the other side. And I think we're going to have to say that, you know, what is our grass and how do we make our grass greener?
Yeah. Thanks for that. I think that also ties into all of this question around, has SA met the WHO yardstick measures in terms of easing the lockdown? Andrew has a question. He says, Ms. Gray, we know that the president is addressing us today. Is there anything new we should expect, or will it be business as usual? And he wants to echo what another colleague Yvette is saying, is that now is D-Day and nothing much serious is being done by our government. So anything new that we should expect tonight from the president?
When the president talks, he's always got something to say. Okay, so he's not just going to get on television and put his mask on. I do think, okay, so, and I'm just speculating here, you know, the most controversial thing at the moment is whether schools should close or remain open. And so, and we know that there's been a lot of interaction with the unions and the Department of Basic Education. We've known that there've been interactions with the school governing bodies, with parents. And so I do think that, I speculate that that the president is going to announce probably a closing of schools tonight. That's my speculation. Or maybe he's going to announce that schools are going to stay open. But there's definitely going to be an announcement at school, and it's either the schools are open or the schools are closed. It all depends on who won the argument. So we'll see. Should we start a bet? Let's see. We could start a bet on that.
Okay, I'm cognizant we have 12 minutes left, so let's power through as many questions as we can get to. So Ntando is saying COVID-19 research has required a lot of understandable speed. How does the speed safeguard participants' rights and ensure ethical conduct? One of the trials that hasn't been able to account to civil society is the TASK BCG vaccine for COVID-19 trial. Has the SAMRC heard about this lack of accountability?
So the MRC was asked to fund the study. And so the first thing that we did with the study was we did a scientific review, and then we did an advocacy. We did a community engagement review, and we did an ethical review of the study to help us make this decision. Because the issues is that, is this a compelling program? Is it biologically plausible? Could you answer the questions? And then can you make sure that that when you do enroll participants, they're protected? And so the MRC as a funder has an obligation to make sure that the studies it funds, that we make sure that the standard of prevention is of a high quality. And so we had a lot of interactions with task on whether they would be able to provide PPE to healthcare workers, and if you can provide PPE to healthcare workers, then then could you is the study would you ever be able to find an answer? And the perverse thing is you don't if you have to if healthcare workers aren't wearing PPE properly to get the answer, then it's obvious that there's the ethics of that you for us. So shall I just say for me as a funder, or the MRC as a funder, is that we don't want to put anyone's lives at risk if we have to fund research. And so the first thing that we would want to ensure if we ever had to fund a research project like that, is to make sure that they would guarantee that they were getting the best standard of prevention. So if you are doing a study in healthcare workers and you want to prevent a COVID infection, then you have to ensure that that the participants get access to PPE and good PPE, and that in every case of seroconversion, you need to ensure that that happened in the community or happened in the tea room, but didn't happen while you were taking care of a patient. And so we've had that. So there's that, and there are a couple of others that are quite tricky. So we are busy. We're going to be having a community engagement about an AD5 vaccine. So previously, the first generation of AD5, we did a trial in South Africa, and we found that it increased susceptibility. Increased susceptibility to HIV acquisition in men. And in terms of the vector, we were never sure whether it was the vector or whether it was the lack of envelope or the antigens that we chose. But following that, we never did any other work with AD5 in HIV vaccines. And then subsequently, there have been different iterations of the AD5, and it's been used in Ebola, and now there are new generations of AD5 that are what they call more mute, immunological mute. And the question that we want to bring to the community is this something that we should be doing in South Africa? And so our first step has been, we've done a scientific review. We thought, okay, let's first do the scientific review. If the scientists say no, then we don't even have to go further. And we spoke to the scientists, and there were some novel things that had a new, besides the other vaccines that have been evaluated at a world level, only looks at spike protein, and this looked at spike and something else. And then looking at the AD5, they had taken four deletions out, and the question is this safe? And so the next step is to speak to community and say, look, this is the vaccine, this is what it is, this are the pros and cons. What is your advice to us? Do we as a country do this? And if we do it as a country, how do we manage, how do we monitor going forward? So this is a partnership, because we can't make these decisions by ourselves, because you have to guide us, because otherwise it's going to be a problem. And we have to look at will the first generation vaccines work, and if they don't, and we've turned our back on something that could have worked, and then we've lost a year, and if it is worthwhile looking at in South Africa, then how do we make sure that we move slowly so we don't make mistakes? And then also we have to look at about access. So a lot of the vaccine work that we're doing, we have to make sure that there's going to be access in the country. And so some of these programs are saying, we will do tech transfer. You can, BioVac can be used to scale up. And so then you also have to look at, that there's a possibility that if we investigate it, if we looked at this AD5, we could also produce it in South Africa. So those are all the kind of things that we have to engage with. And so when we make these decisions, we look at the ethics, we look at the regulatory, we look at the community implications, and then we look at the science. And all of those are important. I can't think of one element of those engagements that aren't important or stronger or less important than the other.
Yeah, thanks for that. And we certainly look forward to engaging on the Ad5 issue. So Glenda, I think we'll take the last question before we wrap up, and certainly we'll get you the remainder questions in writing for some response. But a common thread in a few of the questions here is the issue around Indigenous medicines and Indigenous knowledge. There's a question about, as well from both Andrea and Tando, around the so-called Madagascar cure. And yet at the same time, we've seen headlines of infections and death in Madagascar, despite the much touted cure. What is the MRC doing in terms of Indigenous knowledge and medicine, and what are your thoughts on on what is called the Madagascar cure?
So the MRC, I work a lot with Indigenous knowledge systems. So we've been working a lot with various groups before COVID on HIV. With herbalists and people in Mafeking and Dundee, and what we normally do is the first thing we do is we establish the in vitro potency and whether these plants could work against a pathogen, and once we've evaluated, once we've seen whether there is some activity, we then try and identify whether there's any toxicity. And so whether, first of all, is it potent against the pathogen? Second of all, is there any toxicity? And then you do your animal work, and then you do your human work. And so whatever drug you use, whether it's a chemical compound or a herb or a plant or everything has to go through steps to make sure that it's safe and effective. And so we work very closely with people all over the world and all over the country. I get calls every day about a cure, and I get every day herbs sent to me in Postnet to evaluate. And I take lots of calls because I take Indigenous knowledge system very, and I take a lot of calls and speak to a lot of people who claim that their herb may work. And so we try and work with the Department of Science and Innovation. There is a program that helps us evaluate these products and to take them along the very necessary steps. So SAMRC has specific regulations, and you need to follow them before you can test and evaluate these products in humans.
Yeah, thanks for that. Glenda, the last question before we wrap up. SA fares fairly reasonably in its health research and development, but is not yet there. What do you see as the role of CSOs in advocating for adequate investment for R&D? And what are the side effects of overly relying on foreign health R&D funding?
Well, every country should fund its own research because every country knows what its problems is. So countries should never see science as a luxury. Science is a necessity. It's the way we get out of poverty. It's the way we improve our life expectancy. And so for community activists and for advocacy is to see why science investment is important, and the value of local investment. Because if you're taking donor money, you always are poised to address other people's interests. And so you always have to try and make sure that your interests and their interests amalgamate. Otherwise, there's always problems. And so I'm a firm believer that countries should fund their own research, and that we need to spend a lot of time with our government to explain to them why science matters. And so we do a lot of this. Every time there's a budget cut, I go to Treasury and I explain, I show them the correlation between life expectancy and health, and how if you increase life expectancy, you increase GDP. Show that there's a direct a direct association between GDP and scientific productivity, and show them examples of South Korea, where Japan post-war, Germany post-war, how investing in science actually made their country thrive. And so we need a narrative that we take to Treasury And I've learned that you have to talk to the people who've got the money and develop a relationship with them. But we need much more money. We are so under-resourced as a country when it comes to science. And so if you want to have a vibrant, transformed science platform in the country, you have to invest in it. There's a lot of risks, and so we also find, obviously science, there's a lot of risk, there's a lot of soft money. You're always looking for your salary, and sometimes it's too risky for people who have a lot of obligations to their families, and sometimes it's hard to follow a science career because there's so much uncertainty about salaries and job security.
Yeah, absolutely. Glenda, I think we've made it just to the top of the hour. So it's left for me to say thank you again for making the time. As we can already imagine, you both probably have a very busy schedule during this time. So thank you for making the time to engage. Like you said, and just like science, we believe that engagement is not a luxury, it's an absolute necessity. And we hope this is the beginning of a series of conversations to further strengthen the relationships, not only with advocates, but with civil society in general, to really build on that relationship with the MRC. So thank you again for making the time. We will be in touch after this with any outstanding questions, and we look forward to this evening's address. Thank you everyone for participating, and we look forward to you participating in our call tomorrow that we're hosting. Samukeliso Dube will be speaking to Larry Corey about the new global COVID prevention network. Thank you everybody.
Thanks.
Cheers.
Okay, bye.